Hello and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenauer, and today I'm joined by cardiac surgeon, Dr. Rachel Harrison, and cardiologists, Dr. Estelle Jean, Dr. Kerunne Ketlogetswe, Dr. Amy Marino, and Dr. Barbara Srichai. In honor of American Heart Month, we'll be discussing how to recognize the risks for heart disease in women, understand the non-traditional risk factors, and the steps to keep your heart healthy. We have lots to talk about, so stick around to learn more. Share this broadcast with your friends, and if you have any questions for our experts, you can leave those in the comments below. Thank you guys for joining us. Before we get started, if you all could go around and kind of give a brief introduction of yourselves and the work you do with MedStar Health. I'll start with you, Dr. Srichai.
Hi, everyone. My name's Dr. Srichai. I've been with MedStar probably about 10 years now, I think. It's my anniversary. I currently am primarily at Georgetown, and I serve as the Vice Chief of Cardiology here, but I'm also the Director of the MedStar Women's Heart Health Program.
Awesome. Thank you. Dr. Marino?
Hi, I'm Dr. Marino. I am one of the general cardiologists. I primarily see patients at Lafayette Center in DC. I just joined the company about 6 months ago, but have been really loving it so far. And I have a personal interest in cardiac disease in women and pregnancy.
Awesome, thank you. Dr. Ketlogetswe?
Thanks, Sarah. I'm Kerunne Ketlogetswe. I'm a non-invasive cardiologist and a preventive cardiologist, and I practice out of the Harbor Hospital location. I'm the Vice Chair of Cardiology here, and prevention is near and dear to my heart, and we throw in women's heart health into it too, and that's what I love to do.
Great, thank you. And Dr. Harrison?
Hi, thank you so much for having us and hosting this. I'm a cardiac surgeon. I've been in practice for 5 going on 6 years, been at Union for a year, and Union in Baltimore, and loving it.
Awesome, thank you. And Dr. Jean?
Hi, I'm a non-invasive cardiologist practicing out of Montgomery Medical Center, and I participate with the Women's Heart Program within MedStar. I'm also the Health Equity Lead for the MedStar Equity, Inclusion, and Diversity, and my interest lies in women's heart health, prevention, and cardiovascular.
Great, thank you. And thank you all again for joining us today. So let's get into the questions. So Dr. Jean, heart disease affects both men and women. So why is it important to focus on women specifically?
Yes, it really is important because cardiovascular disease is the #1 killer for women. And unfortunately, it affects 1 in 3. It's the cause of death in 1 in 3 women every year. And so that means that that's 1/3 of our sisters, our mothers, our friends, and our coworkers. And so it's really important that we continue to spread this awareness because unfortunately, only 44% of women know that heart disease is their greatest risk of health. The research shows that cardiovascular disease, for example, kills more women than all forms of cancers combined. And so what I do find is that many of my patients sort of think about cancer because they know someone who's had breast cancer, and so it personally affects them in a different way than necessarily heart disease. So they don't think about it, but we need to continue to do this ongoing awareness so that more women know that it is their greatest risk. And of course, lastly, unfortunately, only 38% of participants in clinical trials consist of women. And so this gap prevents us from getting optimal treatment and care for our female patients so that their needs and our treatment are appropriate for them.
And so my next question was going to be, what do women need to know about heart disease? But I think you covered a lot of that in your last answer. But if you have anything to add about that, go ahead. My next question after that was going to be, why do women have a higher risk than men for heart disease?
Well, I mean, one thing for women to know is that really heart disease and stroke can happen at any point in their lifespan. And one particular statistic that's been shown is that we have higher death rates now in the 35 to 54 age group. So in this age group, more women are dying of heart disease. And unfortunately, a lot of that is driven by risk factors such as smoking, diabetes, and high blood pressure. So again, making sure that you don't dismiss your symptoms and to get treated appropriately at whatever age that you're at, because it really can be heart disease. And other statistics shows that for women 20 years and above, nearly 45%, almost 50% are living with some sort of cardiovascular disease. So again, sort of highlighting that need to make sure that we're getting screened and treated appropriately for risk factors.
And speaking of risk factors, can you talk a little bit more about the general risk factors for heart disease, and then if there's certain ones that women or seem to affect women more than men?
Yeah, so there are two main categories. So we have the modifiable risk factors, so those are the things that we can control, and the non-modifiable risk factors. So that would include your race or ethnicity, as well as age and gender, and your family history. So we really can't control that. But 80% of heart disease and stroke can still be prevented from lifestyle. So focusing on these modifiable risk factors are really important. So that includes high blood pressure, high cholesterol, diabetes, smoking, as well as physical inactivity and a poor diet. So these are really critical aspects of our care that we're in control of. It can go a long way if we optimize it. And in terms of things that we women, in terms of risk factors that puts us at higher risk compared to men, unfortunately, a lot of the studies still show that it's because heart disease is just under-recognized and it's not treated as well. So even though you may be a woman with certain risk factors, such as cholesterol, a lot of times it's not treated as aggressively compared to a man. And so if your cholesterol goes untreated for a very long time, that can then lead to more severe diseases compared if we were a little bit more aggressive with treating some of the risk factors. And then as well as things that make us unique as women is that our blood vessels are smaller than men. So then that can lead to certain diseases of the smaller blood vessels that can contribute to our chest pain, such as microvascular disease. And as well as older age, we tend to have many of our cardiac events slightly later in life. So then many times we have more of those risk factors that then make us a little bit sicker when we do present.
Thank you for explaining that. That's good to know. Dr. Srichai, how do hormones affect a woman's risk for heart disease?
That's a very important and good question. So Dr. Jean had kind of explained about a woman's risk for heart disease and how women tend to develop heart disease, or we see the development of heart disease later in life. And the thought is, our hormones, the estrogen that we have up into menopause is protective in that respect. And that's why we're not seeing this kind of increase in risk until after menopause. And then we start seeing that the risk of heart disease tends to be equate to that of men. We define menopause as, amenorrhea that occurs after, 12 consecutive months. And the median age is about 50 years. And there are studies that show that if menopause occurs early, and by premature, we say is less than 40 years of age, early is between 40 and 45, but women who have early menopause or premature menopause are at increased risk for heart disease, and compared to women who have the median age of menopause around 50. And there was an early study back, so that the whole thing with hormones and treatment, to replace, because I know a lot of women when they go through menopause, particularly I think young, when it happens earlier, will have a lot of symptoms related to menopause and the whole issue of hormone replacement therapy. And we used to think it was a beneficial thing, but then early studies suggested maybe it's not beneficial. And we kind of now take more of an individualized risk approach, and newer studies that are out compared to the older studies suggest it may be beneficial, particularly in those that have earlier age menopause, or those who are just undergoing menopause, particularly to help with those vasomotor symptoms that women will get related to just kind of like that change in the hormones. And and some small studies suggest there may even be a beneficial effect of hormones at that earlier stage. We still are trying to understand the whole role of hormones and whatnot in and its effect on heart disease. But that's regards with menopause. And then we know in pregnancy, there's also like a shift in hormones. But pregnancy, I think Dr. Jean touched on some of the traditional risk factors and some non-traditional risk factors. And some of the ones we just mentioned here, early menopause. Another is complications during pregnancy. can be associated with increased risk of heart disease. And we're still trying to understand that, but there are 6 conditions that can be has been associated with increased risk for cardiovascular disease: high blood pressure during pregnancy or preeclampsia, especially gestational diabetes, preterm delivery, so before 37 weeks, small for age gestational delivery, pregnancy loss, and placental abruption. And so those are kind of things that most physicians, I think even cardiologists, may not even, think about when they're asking or speaking to their female patients, but are important to consider. And for we as women to think about also, that things that happen during our pregnancy can affect our risk for development of cardiovascular disease later in life. The other kind of question we always ask our patients is polycystic ovarian syndrome, because that also has an effect on cardiovascular disease risk. Patients who have polycystic ovarian syndrome tend to develop diabetes, dyslipidemia, or change in their cholesterol panels, that are sort of associated with traditional risk factors that we think of with cardiovascular disease, but there may be other kind of non-traditional aspects of polycystic ovarian syndrome related to the hormones that may also be affecting what we see.
Thank you. That's good to know. And we talked a lot about risk factors. Dr. Jean covered a bunch. You covered a bunch. Is there any more that we might have missed that are specific to just women? And why do women present with heart disease differently than men?
So some of the other, I think we touched on a lot of the different risk factors, that ones that affect women more so than men. The other thing is breast cancer. We don't think about heart disease and breast cancer, but some of the therapies we use in breast cancer, such as radiation and some of the chemo agents, can have adverse events on the heart. Sometimes, depending upon what the agent is, can be more kind of at the time of treatment. Some can be later on in life. And we are working on breast cancer therapies, but that breast cancer does affect men too, but it just predominantly will affect women over men. And I think the other sort of more, I don't want to say more specific, but often disease processes that occur that we see more in women than in men would be autoimmune diseases such as lupus or rheumatic diseases that can be associated with increased inflammation, which we know has an effect on development of atherosclerosis and plaque in our body, and so is also one of the risk factors that we sort of considered as a little more specific for women than men.
Great,
and I think your other question was about, I forgot what your
that's okay. It was, why do women present with heart disease differently?
Oh, well, I think Dr. Jean touched a little bit on this about the hearts, the smaller hearts and the smaller blood vessels, propensity to affect the microvasculature as opposed to the macrovasculature. So the smaller blood vessels as opposed to the bigger blood vessels. And unfortunately, most of our testing that we have, our traditional testing we use for heart disease, is looking at the big blood vessels, and that's the ones that men mostly have. And we're in the process of developing newer modalities or new imaging tests to investigate those smaller blood vessels that tend to be more affected in women and probably represent more of where the blood flow is to the heart muscle. And so I think kind of those factors have an effect then on how women present. And so we think of, and I even have patients come in my office and say, it's not my heart because I don't get that crushing chest pain that we think about, or the elephant sitting on my chest. I just have this tightness. And I'm like, well, that could be heart disease too. It's hard to, or sometimes some stomach related issues. And I think one thing that we know from our data is that women tend to have a lot of additional symptoms in addition to, they may have some chest discomfort, but they may have like 3 other associated symptoms: shortness of breath, nausea, discomfort in the abdomen, that may lead the clinician to think, oh, it's not your heart because you have all these other symptoms. But that can all be heart disease. And so it's important to be aware of that.
And I think that also relates to my next question, which was asking how warning signs of heart disease are different from women versus men.
So kind of tied in with that. And just I think, as Dr. Jean had pointed out earlier, just that recognition, both by we as the patient, women patients, but also by the clinicians and who are treating us, to be cognizant and aware of that. And it is penetrating into the medical literature and in the guidelines that it's that heart disease presents differently in men and women, and just to be aware that these kind of different factors in women may actually be heart disease, as opposed to blowing it off as, oh, it must be your stomach, or it must be not the heart.
Right. Thank you for explaining all that. Oh,
now I just
go ahead,
want to
yeah.
add as well. So in terms of additional risk factors that mentioned earlier, but diabetes, obviously it does impact both men and women, but for unclear reasons, actually women with diabetes are actually at higher risk for having heart disease compared to men. So again, it's really important that if you have diabetes to have regular follow-up. It's also recognized that some of the symptoms of heart attack can be different in a diabetic patient. It could be more indigestion, more fatigue, and not necessarily that crushing chest discomfort. And smoking is another one. While it is a traditional risk factor, but women are actually at higher risk of having heart disease if they're a smoker compared to men. And then lastly, an important risk factor, especially in this time of COVID, is the chronic stress as well, depression. So we do know hormonally that women, when they have excess mental stress and depression, it can increase their risk of having more unique heart attack conditions, such as broken heart syndrome. And then unfortunately as well, in the various roles that they play, they may, if they're experiencing depression or excess stress, may not seek medical care in a timely way, or just ongoing treatment for their underlying risk factors.
Interesting. That's great to know. Thank you both for adding on to that. And Dr. Ketlogetswe, what are your recommendations for reducing the risk factors of heart disease in women?
That's a great question. I'm going to circle back to Dr. Srichai and Dr. Jean. I had a patient yesterday, so I'm covering the hospital this week. And I had a patient who could be our textbook case for this week. She's a diabetic, she smokes, she has mildly elevated blood pressure. And for weeks, she's been having pain in her arms whenever she does stuff. And she didn't know what to do with it. She had chest pain 2 days ago and still didn't come to the hospital. And it wasn't until she was walking across her parking lot to get lunch and she had more pain. And she called her daughter, right, to say, I'm having this pain, what should I do? And it highlights that women, A, can present differently and their symptoms are different. And number two, that despite having all these risk factors, she still didn't even put 2 and 2 together to say, I'm having a heart attack. She was having a heart attack. We sent her to the cath lab this morning and she's got a complete blockage in one of her arteries, and they ended up putting a stent in one of her arteries. So I think the biggest thing for people to understand is to know your risk factors first and foremost. So to our friends who are listening today, do you know what your blood pressure is? Do you know what your cholesterol is? Do you know if your weight is in a healthy range? So actually knowing what your risk factors and knowing your numbers is part of the battle, right? Knowledge is power. And we're telling you the trend that we're seeing in this country is that more and more younger women are presenting with heart disease. So this is not a disease of old people or something that we should worry about. I'll think about it when I'm older, but that even as a young person, the trends and the habits and the things that you do when you're younger lay the groundwork for your risk for heart disease in the future. So I think that's the biggest thing, is to know what your risk factors are. And if you have some of the obvious ones, for example, like if you smoke, stop smoking. There's some things you can't change, but other things are, if you can, change them now.
Right. Thank you. And what advice do you have for women to proactively discuss their health with their primary care physician? You just mentioned knowing your blood pressure and cholesterol levels. Is there anything else that you'd like to add?
I think it's really important to also bring your concerns to your primary care physician. So don't sweep symptoms under the rug or assume that something is just, it's my muscles or it must be my lungs, but that symptoms that seem unrelated to heart disease could be. So I think it's very important for people to speak up and to advocate and to request testing when they see their primary care doctors. So knowledge is power, and also advocating for yourself is really important.
I think that's great advice. Yeah, I know it can be easy to, like you said, sweep your issues under the rug, especially if they're not, really affecting you terribly, but then it's just going to pile together and could turn into something bad. So when is the right time for a woman to see a cardiologist?
I think all of us on this panel would say it's never too early, right? again, with heart disease becoming more prevalent in younger people, and also seeing an increase in the risk factors for heart disease going up in our population, so be it diabetes, be it overweight and obesity, as those risk factors go up, I think it's never too early. Our motto is prevention is the way to go, right? Our goal is to prevent heart disease. And so if you have risk factors for heart disease, cardiologists tends to be more aggressive about managing those risk factors and doing some additional testing, for example, to look for things that we could do to augment or bring those risk factors under better control. So I don't think it's too early to see a cardiologist.
Thank you. And so we talked about how, the differences in risk factors and signs for women and men. How is the treatment different for women than men, if it is at all?
When we're managing the traditional risk factors, I wouldn't say that the treatment is different per se. We do the same things. We try and get to certain targets and to certain goals, but that you may have to have a slightly different approach and a threshold with women. The way that a woman may react to one medication, for example, may be different. And I think part of the reason that people aren't as aggressive in women is because if a woman speaks up about a side effect, people will back off and won't be as aggressive because they don't want to, for that person to have the side effect, as opposed to switching to a different agent, going low and going slow, and up titrating or increasing things slowly. So I think that the treatments that we use just have to have a more directed approach, as opposed to abandoning or being not as aggressive about things because you're treating a woman.
Great, thank you. I'm going to pause for a minute and say, if you're just now joining us, thank you for tuning in. We're here today with cardiac surgeon Dr. Rachel Harrison and cardiologist Dr. Estelle Jean, Dr. Kerunne Ketlogetswe, Dr. Amy Marino, and Dr. Barbara Srichai. Did you know heart disease is the leading cause of death for women in the US? And in honor of American Heart Month, we'll be discussing how to recognize the risks for heart disease in women and ways to keep your heart healthy. We have a lot more to discuss, so stick around to learn more. Share this broadcast with your friends, and if you have any questions, please share them in the comments below. Going back to our questions, Dr. Marino, do women tend to ignore or explain away their symptoms more because they're moms, caregivers, stuff like that? And if so, what would your message be to women?
I do. I think women tend to downplay their symptoms. I like to say that women are strong and they tend to put their needs before, or put others' needs before their own. I think women still take on much of the responsibility at home, as you said, as mothers, caregivers, wives, etc. And it can be really hard to put those roles on hold. But it's important to address those symptoms and concerns early. We know that the big things and bad news don't really get better with time. And all those people rely on you to be around. So make time for yourself and make sure that you pay attention and listen and talk to your doctor. And don't explain away those things because, as everyone else said, it might be nothing, but it might be something, and it could be your heart. So it's better to make sure.
Exactly. And would you say, is there a bias against women when they're seeking care at all? Do women tend to be brushed off a little bit when they're explaining their symptoms? I don't know. What is your opinion on that?
Yeah, I think historically women's concerns and symptoms have been more likely to be dismissed by doctors. I've been told that they're related to stress or hormones or weight or menopause or so many different things. Historically, medicine has been very male dominated. There have been fewer women in studies, and we've been focused on symptoms in men. And I think that's a huge blind spot that we're trying to address, but it's slow going. And even women that don't have traditional risk factors, again, as everyone has already mentioned, those like hypertension and diabetes can have other types of heart attacks like spontaneous coronary artery dissection or SCAD, or disease of the small vessels that we call microvascular disease. And those aren't the traditional patients that doctors have thought about when they come with their symptoms. So yes, they do. And so make sure that you pay attention and don't hesitate to speak up and get care early.
And go ahead.
Oh, I was just going to say, because I think just to that point, I think sometimes some women I see come to see me and they're hesitant to tell me about their symptoms because they feel like, oh, it's nothing. And maybe it's because of how exactly what you're saying about how they've been treated in the past. That, oh, it's nothing, and they don't want to waste your time. But I would say, you have to be an advocate for yourself, and you know your body the best. And I just that's your provider is there to give care to you. So you should make the most out of it and not feel like you're wasting that person's time. Because I feel like that's, as women, that's how we feel, like this is nothing, but you should definitely, because it's something to you.
Exactly. And you mentioned advocating for your health. My next question is, how can women be better advocates for their health, especially their cardiac health?
So learn about your risk factors, know what your blood pressure is, get your A1C checked to see if you have diabetes, know what your cholesterol is, and learn about those non-traditional risk factors that have been mentioned, like complications in pregnancy, fibromuscular dysplasia, early menopause, breast cancer treatment, and also learn about what your goals are. So you can also play a part in trying to make sure that they're well controlled. And don't be afraid to speak up when something doesn't seem right. Like Dr. Srichai said, you know your body the best. And so if something's not right, then ask about it, ask questions, ask about the guidelines, trust yourself, and find a doctor that you feel listens to you so that you can make sure that everything's being addressed.
That's great. And we've mentioned this a couple of times too, but I think it's important to reiterate. Can you talk about the importance of not delaying your care?
Yeah, getting care early can make a big difference. When we talk about heart attacks, we say that time is muscle. And so if you wait too long, then there can be complications that sometimes we can't fix. And so it's never wrong to make sure. And so listen to yourself, listen to the symptoms. If it's nothing, it's nothing, but it might be something. So make sure that you go early.
That's great. Thank you. And Dr. Srichai, what is MedStar Health doing to address the specific needs of women's heart health?
Well, hosting
Hosting this.
question and answer, things like this, exactly. In addition, we have a women's heart health program because we recognize the need to increase awareness and provide care for women who, and we specifically said heart health because not everybody has heart disease, but that doesn't mean you don't, the big part of this is prevention. And so cardiologists don't only see patients who have heart disease, we prevent heart disease too. So that's a big component, as has been brought up by by the previous speakers. The other thing is that we have a heart healthy quiz so that you can learn about your risk factors and maybe see, are you at a higher risk for having heart disease? And there may be underlying risk factors that we haven't even mentioned here, but I think we didn't touch about on ethnicity, but that also has an effect on your risk, your underlying risk. So on our website, which I think they'll have up for people to see later, or a link, but on our website, we do have our quiz on there, as well as some content that is specific for women's heart disease that we're hoping to update and make a little bit more user-friendly. But all the providers within our system who have a specialty within women's heart disease and heart health are on there, so that they're easy to find and easy to make an appointment with. And kind of spread out throughout the MedStar is pretty long reaching in terms of the Maryland, DC area. So we do have providers throughout the system.
Yes, thank you. And thank you for mentioning the website. Yeah, we will be posting a link to the page in the comments at some point during this broadcast. So be on the lookout for that. Dr. Harrison, as a physician, how do you assess women for heart disease differently than men?
Well, by the time patients see me, usually 9 times out of 10, their assessment's complete. But it's sort of how we tackle the surgical question that might be different for men versus women. As we discussed, women typically present, or they're more likely to present with atypical cardiovascular disease symptoms, and therefore by the time they're recognized and by the time they come to me for surgery, they're usually further along in their course. They have more comorbidities, they're more frail, and they have more advanced disease. So we have to take all of that into consideration when we're planning surgery on women.
And then that kind of goes into my next question. From a surgical perspective, are there differences operating on women versus men, outcomes, length of stay, success rate? How can you talk about that?
Sure. So we know in our own personal literature that in our specialty that the female sex is actually known to be a risk factor for morbidity and mortality after open heart surgery. Some studies show that women are at greater risk of death early on after heart surgery, but they also have a higher risk of postoperative stroke compared to men. And when you compare the different types of open heart surgeries that men versus women are getting, more women are receiving mitral valve surgery while more men receive aortic and coronary bypass surgery. That's just due to the pathology that's going on inside their bodies. Women tend to have higher rates of sternal wound infections and longer lengths of stay compared to men undergoing similar surgeries. And then from a surgical perspective, when we break down the types of surgeries and look at the difference between the genders, we know that in coronary artery bypass surgery, that's where you bypass blockages in the arteries of the heart, that multi-arterial bypassing using multiple arteries as grafts rather than veins is shown to improve survival. That being said, the STS, which is our professional society literature, tells us that many surgeons are less likely to use multiple arteries as conduit in bypass for women. We don't know why, but the facts are what they are. This translates ultimately to suboptimal surgical revascularization in women and hence worse survival rates, which is exactly what we're seeing. Women also tend to have more challenging anatomy from a surgical perspective. For example, their tissues are more fragile and they're more prone to injury at the time of surgery. So we as surgeons have to be very careful and take that into consideration when we're operating on women. Coronary arteries are typically smaller and more diffusely diseased than their male counterparts. This makes their operations more technically challenging overall. When you look at mitral valve surgery, that's the valve that goes from the back of the heart to the front, from the left atrium to the left ventricle. Older women typically have calcium burden on their valve. This can make surgery extremely risky and challenging. Furthermore, the pathology of mitral valve disease is different in men versus women commonly. Men will frequently have leaflet prolapse, whereas women typically have calcified leaflets. This translates to a greater repair rate in men, while women more frequently have to have their mitral valve completely replaced. In aortic valve surgery, this is also more challenging in women because women typically have a smaller annulus. That's the base of the aortic valve where it attaches to the aorta. And they're higher risk for patient prosthesis mismatch, meaning the valve that we put in to replace a defective aortic valve might be too small for the flow that they require across the valve. The way we get around this is to do an annular enlargement procedure. That's where we make room in the aortic root for a larger valve. But doing that adds a fair amount of complexity and time to the operation in what would ordinarily be a straightforward case in the male population. On the positive, women do have a lower bleeding risk postoperatively, and that's felt to be due to estrogen's procoagulant effect. That said, women still have a higher red blood cell transfusion rate postoperatively than men, and that's associated with delayed recovery.
Okay. Thank you for explaining all that. That was a lot to go through, but thank you for explaining that all. So what advice do you give to your patients pre and post surgery?
If I have enough time before surgery, it's always good to optimize their nutrition. But either way, after surgery, I still coach my patients on optimizing their nutrition because that's going to facilitate recovery. I just explain to my patients that going through open heart surgery is like running a marathon, and you optimize your body before and you take care of your body afterwards so that you can heal. Besides nutrition, I coach them on deep breathing exercises to kind of prep their lungs so that they're at lower risk for pneumonia, and walking is a big one.
Okay. And is there any cardiovascular guidelines that are specific to women?
Our current surgical guidelines for cardiac surgery don't plainly differentiate between men and women.
Okay, thank you. We have a couple of audience questions that I want to get to really quick. So I'm just going to go through and ask them. Feel free, any of you guys can chime in to answer. The first one that we have is from, let me go, sorry. Trina wants to know a little bit about diet, which we've mentioned. You talked about talking about their diet before surgery. Can you talk a little bit more about that and what is, good for them to eat and what's not? She was asking about what good fats are good and what fats are bad.
In terms of diet, generally speaking, Mediterranean diet, we do have great research data that shows the benefit long term, but more of like a plant-based Mediterranean diet. So you can create a meal around more fresh fruits and vegetables and fiber-rich food, beans, legumes. And if you're going to use meat as a source of protein, choosing lean meats and chicken or fish instead of your red meats or fried food. And a common question patients will have for me are about egg intake. So try to limit that to no more than one egg a week. But yes, the general research is really showing us sort of the benefit of more whole foods, unprocessed, again, plant-based, and avoiding a lot of the processed foods, because really the studies are showing how impactful diet is in terms of the risk factor, and the more processed food that we eat, the higher the risk for multiple diseases, including heart disease and stroke and dementia.
Great,
I
thank
tell a
you.
lot of my patients that, food is medicine, right? Much in the same way as I give a lot of prescriptions for things, but that food is medicine as well. And people can often feel very overwhelmed when we tell them, eat a Mediterranean diet, for example, and they're like, how do I start? And I say, do one thing, substitute one thing in your diet. If you're somebody who eats red meat 3 or 4 days a week, see if you can cut the red meat down to once a week, and then less frequently as we go on. If you're someone who drinks soda, substituting soda for water is a big dietary change for people in terms of excess calories and unnecessary sugar. So I tell people, some people cannot revolutionize their diets overnight, but by changing one thing at a time, and the more plant-based that you can eat, the more meals that you can substitute, having a meat protein as the main source of protein, it makes a big difference. So one step at a time.
Great, thank you.
And in terms of plant-based diet, I think sometimes though, you can go down the wrong path and eating highly processed plant-based foods. So being mindful about reading the labels is really important, because certain patients are just very, very salt sensitive. And so part of being healthier and of course managing your blood pressure is learning how to read the labels. And so while it may be a vegetarian substitute, but if it's loaded in sodium, if you can carve out the time to make whole, fresh, unprocessed food, it's always better for your health than necessarily highly processed meat substitute as well.
Great,
One-
thank you.
One thing I tell my patients after surgery, they've got a lot going on after having just had surgery. They've got a lot to think about. They're stressed about their wound and pain and everything. So I try to keep my instructions pretty simple. And one way that I describe to patients how to eat healthy and take care of themselves is if it's brown, if it's not colorful, stay away from it. That's a simple way, make your plate colorful. And if it can stay on the shelf for a really long time, then probably not a good idea. So try to eat fresh, colorful food. And that's somehow, I don't know if that's exactly 100%, but that's a way that I can simply explain it to patients when they have a lot else going on in their mind.
Yeah, exactly. Thank you so much. And thank you for your question. We have 2 questions that are asking about statins. Mary asks, what's their purpose? And then Sam is asking if cholesterol levels are good, are statins or statins really needed? Don't know if I pronounced that right.
I can start. I'm sure other people can join. But so statins, I guess the first question was just about their purpose.
Mm-hmm.
And so we've always traditionally thought of them as cholesterol drugs and medications to help with lowering the cholesterol levels. And we do use them in that purpose. And they have the most data to support them in terms of reduction in cardiovascular risk, so reduced heart attacks and strokes with the use of statins. If the cholesterol levels are good, it depends then, because what I tell my patients is, if you have heart disease, if I see that you already have atherosclerotic plaque and your cholesterols are at this level, which may be good, but maybe high for you, or it's at a level that for you are still developing plaque buildup. And so even though this is what by their guidelines we're saying are fine, for you, you've already developed plaque on this, and I'm trying to prevent you from having a heart attack or a stroke. So I want your levels to actually be a little bit lower in order to prevent this plaque buildup that you're getting to progress. So in addition to lowering cholesterol, it is thought to have some anti-inflammatory effects. So something, and again, it's kind of like this black box, but that development of plaque and stabilization of plaques. So a lot of times patients will tell me they have a calcium score, and I'll say, well, you know, you're pretty high risk for having a heart attack or stroke. Why don't we start a statin? And then they ask me, you know, does this dissolve the plaques? Or does this make the calcium score get less? Does it dissolve the calcium? And I always want to caution, no, unfortunately, it doesn't dissolve the calcium. I'm not even sure if you dissolve the calcium, if that's even going to be beneficial, because it may make stable plaques more activated and increase your risk for having heart disease. So in addition to the cholesterol effects of statins, there is this sort of plaque stabilizing effect that we're still trying to understand. And we think part of it may be like an anti-inflammatory effect. So the plaques you do have are then less likely to rupture and then cause an acute stroke or heart attack. I don't know if any of the other physicians want to join in or comment up further on what I've put there.
And I think the statin question comes up frequently for my patients because they're still sort of, many of my patients feel they should only do it with lifestyle, that, you know, they should eat, you know, healthier and exercise. But I also always remind them that 20% we can't control, right? So again, as I mentioned earlier, 80% of heart disease and stroke can be prevented from lifestyle, but there's that 20%. And sort of the biggest way that you can at times impact your own personal risk is picking your parents, which we can't. And so for many patients, they kind of need that integrative approach. And it's not a failure to their lifestyle, but it's just their genetics. And so if we can kind of remove some of the stigma or shame of needing to take drugs to reach optimal health, because ultimately that's the goal, reducing your risk for stroke and heart attack so you can, you know, thrive in your later years. And just that reminder again that sometimes based on your genetics, you may need the statins for all those other things that it does. It has, you know, what's listed, decrease inflammation, plaque stabilization, because soft plaques can be bad and more at risk for having a heart attack, which women, we tend to have more of that soft, potentially unstable plaque, but versus statins can then transform it into a harder, stable plaque, thereby reducing your risk of a heart attack.
Thank you so much, all of you guys, for explaining that. And thank you for your questions. We have two pregnancy-related questions. So I'll ask the first one is from Nana. They ask, what's the treatment approach for women who continuously get high blood pressure with pregnancies and that resolves after delivery? And then the next question is from Ashley asking, how do you approach discussing risks and complications of pregnancy to female patients? And she even asks with pre-existing cardiovascular conditions. So I don't know if one of you guys want to take one or the other. I can also re-ask them again if you need me to, because they were kind of long.
I can talk about the blood pressure in pregnancy.
Sure.
We know that women that have high blood pressure before they go into pregnancy are more likely to have high blood pressure during pregnancy. And we treat high blood pressure both before and during pregnancy. We try to keep the blood pressure less than 140/90. We know that's better for maternal outcomes and better for the baby. Some women will develop gestational hypertension or high blood pressure during pregnancy. And we also want to treat that in the same way. Sometimes it will get better after pregnancy, but we know that those women are still at increased risk down the line of having cardiovascular disease. So while we may be able to stop their blood pressure medications, we have to pay close attention to the likelihood that they might develop high blood pressure later or heart disease and control all of their risk factors. Women that have high blood pressure are also at higher risk of preeclampsia. And so that needs to be managed by the OB team, and we make sure that the blood pressure is well controlled to keep bad things from happening.
And just to add on, you know, an important aspect of cardiology has been the development of a better collaboration with OB and cardiology and the development of a field called cardio-obstetrics. And it was in response to several things: higher rates of complications during pregnancy and prior data showing how cardiovascular disease is the leading cause of death in women during pregnancy and in the postpartum period. And another topic that we haven't fully delved into is the health disparities and how it's not only an issue in terms of overall cardiovascular disease, how minority patients are at higher risk of dying from heart disease and stroke, less likely to be an optimal medical therapy, less likely to receive standard of care. But as it pertains to pregnancy in particular, unfortunately, Black women are 3 times more likely to die from pregnancy-related complications in the U.S. And overall, our rates in the U.S. in terms of maternal deaths are the highest in an industrialized country. So, but review of the data still shows how cardiovascular disease is a leading cause. So having better blood pressure control is so important, and for long-term follow-ups, because studies are showing that as early in the 40s, when you do a CAT scan to look for that calcium buildup, in their early 40s, if you've experienced preeclampsia or have had gestational diabetes or high blood pressure, there's early onset of hardening of the arteries or atherosclerosis or plaque and the calcium score. So it's really highlighting the research showing how pregnancy is sort of that first stress test that women go through, and you really can't ignore the data. And you really have to be aggressive as far as managing all of your risk factors for both healthy mom and healthy baby.
Thank you. And then to say Ashley's question again, how do you approach discussing these risks and complications to patients with complications of pregnancy, to patients with pre-existing cardiovascular conditions? And maybe to add on to that, would there be any advice you'd give for how they could bring it up with their doctor if their doctor doesn't bring it up first?
I think an initial part is that preconception counseling. I mean, it's so important. And thankfully, I've been personally seeing more female patients seeking my consultation before getting pregnant, because it's just an important time where you can go over all of those risk factors and can have the conversation where it's not as sort of stressful. Because once you're pregnant, it becomes a little harder to go over these statistics without adding additional sort of fear and anxiety during the pregnancy. And then postpartum, we know that 4th trimester, right, which is the first 12 weeks after delivery, how crucial it is in both outcomes for both baby and mom. But that trimester period is busy, right? You have your postpartum check, you have the baby wellness check, and potential postpartum. And obviously the discussion throughout the pregnancy is important as well as the postpartum. But if you are thinking about getting pregnant, getting connected with a healthcare provider earlier on for that preconception counseling can really go a long way. Because another concerning data point shows that currently 50% of women going into pregnancy have less than optimal cardiac health. So we do need to get better at educating our patients about the importance of healthy weight, exercise, nutrition, stress management before getting pregnancy. So it's much easier to continue that while you're pregnant.
I think it's also important to keep in mind too that even if you have cardiovascular disease, you know, we get many people through healthy and safe pregnancies. I think the key thing is co-management. So it's a multidisciplinary approach. It's your OB, it's your cardiologist, it's frequent visits, frequent monitoring, and we get a lot of people through safe pregnancies. But the key thing is, you know, making sure that you're seeing the right doctors.
Exactly. Thank you so much for both of you for explaining that. Our next question is from Brent. How frequently should a woman in their late 60s to 70s without long-standing hypertension and mild moderate valvular disease be getting cardiac stress tests to follow progression, or cardiac stress test / stress echo to follow progression?
So I can start with this one. So if it depends upon how significant the valvular disease is, and generally it's generally an echo, not necessarily a stress echo, unless there are signs of ischemia or the valvular disease is getting worse, and we're concerned about its negative effects on the heart during stress, such as causing things like pulmonary hypertension acutely during stress. But in the mild, and so there are guidelines that are out there in terms of how frequently office visits as well as echocardiograms. Usually if it's in the mild range, we usually say, you know, maybe 3 to 5 years. As you get into the more moderate range, then it's more frequent. And if you're in the more moderate to severe, it'd be like, you know, office visits at least every 6 months, and then imaging 6 months to a year, depending upon how closely we're following it. It also depends upon what the cause of it is too, because we know some valvular diseases take years before you might experience any significant symptoms. So things like aortic stenosis don't happen suddenly. They usually take years to develop for patients to have symptoms, even things like rheumatic heart disease. The clinical follow-up is to make sure that there are no kind of warning signs that something's progressing. But then the imaging to kind of follow the progression. So it depends upon the type of disease and what's causing it. And then there are some diseases that, we don't, that you may have a risk factor for developing acute worsening of the disease, and it's unpredictable in that sense. So we just always I warn my patients, that if you have, for example, myxomatous mitral leaflets, a tendency for prolapse, sometimes those chordae can rupture and you might get suddenly worsening of the leakage. And you might get, I always tell them, like, if you suddenly have symptoms that maybe you might think it's a cold or a flu, and you might relate it to your lungs, that could be something from your valve. So again, things like that, I would say you'd have to talk to your cardiologist about what the recommendations are and why they're recommending it as frequently or maybe not as frequently as you may have thought.
Thank you. Another question from Ada. They're asking, might butcher this, Takayasu's arteritis. Should I get screened for HD even though I have no symptoms?
So Takayasu's arteritis is a vascular disease.
Of close.
Yes, you're very good. I'm unfortunately, it's a little, it's an inflammatory disease, and it tends to be more in the Asian population, young Asian women, more predominantly female affected. And we usually do screen because it's a blood vessel disease. I'm not as up to date in terms of how frequently that screening is in the asymptomatic patient. And then, the long-term treatments. And I don't know, Dr. Harrison, if you have any data in terms of, if the vascular abnormalities that are seen or the narrowings, do we treat the treatment for that, and how we follow that prior to treatment.
This question also raises a good point, though. She has a vasculitis. She has some vasculitis are associated with abnormalities in your aorta. Some are associated with sort of smaller vessels, and so there is a screening protocol. But some diseases, if they're more associated with inflammation, for example, can increase your risk for cardiovascular disease. So one of the things we've talked about, why women's hearts or women's heart disease can be different is things like lupus and rheumatoid arthritis, which tend to have a more female predominance or more women being affected, can be risk factors, right? So even if you have an underlying chronic inflammatory disease, that's also a good reason to be more aggressive about your screening and management of your risk factors, because it affects the blood vessels in the long term, and anything going on in the arteries may make it more likely to form plaques or blockages in the arteries, and you want to be aggressive early on in looking and preventing those.
Thank you. And before we wrap up, we also got a comment from one of our viewers asking us to talk about, include some information on spontaneous coronary artery dissection, or SCAD. So if you guys could bring a little bit of awareness to that, talk about it, what it is. They mentioned it's often misdiagnosed as a panic attack. So could you guys talk about that a little bit?
I think Dr. Marino had mentioned it when she brought up the different ways that women who have who present acutely, the different other types of disease processes that may present with similar symptoms. SCAD is one of the things that is more affected in women than in men. Can occur around the pregnancy time. I think the biggest thing is awareness, both on the clinician who's treating the patient, as well as you are taking care of your body, as we've talked about here. but it's what we say, it's one of the things that we think about with a person coming in who we think may be having a heart attack, and maybe the vessels don't look as bad, but can be very difficult to diagnose also. And some of the non-invasive imaging tests may miss it, and it's often diagnosed on heart catheterization. And so again, a little bit of that is just the increased awareness of it, and the risk factors, or rather the presentation when it can occur.
And I would say there definitely is an increased awareness of it. And I've had the fortunate opportunity of working with many of the interventionalists at Washington Hospital Center. And it's definitely something on your mind if there's someone who's presenting with atypical symptoms, they'll think about it more broadly and do the special additional testing to look for it. So we need to learn more. Our treatment, thankfully, has improved over the past several years. Before we would put a stent if someone presented with that, but the data showed that it wasn't beneficial and potentially harmful. So we moved away from that. And there are various SCAD communities where patients can get various support. But yes, we are thinking about it more, especially around the time of hormonal fluctuations via pregnancy or menopause, and there's still more to learn.
Thank you. Thank you all for your questions. Before we close, we've gone through a lot of information today, but is there any important information that we've left out, or any messages you'd like our viewers to take away after watching this broadcast? I'll go around. I'll start with you, Dr. Harrison.
I think the most important thing, we've kind of really hit this hard, is really know your body and listen to it, and know that women are not the same as men. And so we present differently, we have different symptoms, we have different pathologies, everything is different. So you can't just assume that there's nothing wrong when you have a little bit of nausea. So I think it's important to know your body and really pay attention to that, particularly if you go to the ER or your primary care doctor and you feel like you're not getting the answer that you want, to press on, because it's all about you as the patient, and really be an advocate for yourself if you feel like there's something off about your body. And also know your numbers. I might have stole that one from Dr. Ketlogetswe. Know your numbers, because it's really important.
Great, thank you. Dr. Srichai?
I think one thing we didn't really touch upon was just testing, cardiovascular testing, and the shared decision making. So there are a lot of different tests out there that might be recommended. Some have, they're all safe, but some have a little bit more risk than others. Some are a little bit more proven in certain conditions and maybe more considered more safe. Or we always try to avoid radiation in women as much as possible, but everybody has their own preferences. And I would say to just make sure that when you're discussing about if your doctor's recommending a certain test, to discuss with them if you have any concerns about the test, or just to understand it, because your physician may not understand your preferences or your values and how that affects what kind of test they may recommend or you may end up choosing. So just something that we didn't really touch upon, but is important, I think.
Thank you. Dr. Marino?
I think everything's been well said, but just advocating for yourself, and also back to the testing, that there are some tests that aren't super common necessarily. Not every primary care doctor will initially offer them or talk about them, but there are some tests that can try to figure out what your personal risk is compared to other people, and that maybe you need to be treated more aggressively than others. And so asking about those opportunities too, I think is a good idea.
Thank you. Yeah, we're getting to the point of this question where it's just going to be, yeah, what they said. So Dr. Ketlogetswe, did you have anything to add?
I think one of the things that's great about being a cardiologist is that heart disease is preventable, right? We get to work in a field where we can actually slow down or halt the progression of heart disease. And so I think that's the thing that people have to remember too, is that you can change your trajectory and you can actually modify and change what your outcome will be in the future. So I think it's really important for us to also spread a hopeful message that we live in an era where we've got great therapeutics, both pharmacological and non-pharmacological. We've got great interventions, which 20 years ago may not have been an option for people. So we have lots of ways to treat heart disease. And so it's something that even if you get diagnosed, we can manage and you can still have a fruitful and productive life.
Thank you. And Dr. Jean, you drew the short end of the stick. You're at the bottom of my screen. So.
And I did mention it earlier, but yeah, the health disparities, unfortunately, is still an ongoing issue. And I'm hoping that this conversation today sort of highlighted the need for us to continue to really focus on prevention, but also continue to look at all the various, what we call the social determinants of health, the things that can make it a little bit more challenging to get care, be it access or the environment, so that we all can receive equitable care. But one thing I definitely see frequently with my patients is they get frustrated with the system. They just sort of check out at times because it's just hard. But remember, this is your health. And so if the provider is not listening to you, go and find someone else until you're getting the best care and adequate care so that, again, we can live thriving and helpful, lives into our later years without being plagued with excess heart attacks and stroke.
Thank you so much. That is all a great way to wrap up our broadcast. That's all the time we have for today. Thank you guys again for joining us, taking the time out of your day to answer our questions and share this super important information. And thanks to our viewers for tuning in and asking your questions. If we didn't get to all of your questions, we will make sure to respond in the comments after this broadcast is done. For more information or to schedule an appointment, you can visit our website, which, as we mentioned before, we'll be posting the link in the comments below. We'll see you next time, and thanks again for joining.